Hello, everyone. My name is Aravind Veerapandian. I'm a pediatric neurologist and a neuromuscular specialist at Arkansas Children's Hospital.
Hi, I'm Craig Zaidman. I am a pediatric neurologist, and I also specialize in neuromuscular diseases, and I'm at St. Louis Children's Hospital and Washington University School of Medicine in St. Louis. I'm glad to be here to talk about practical considerations in the management of Duchenne muscular dystrophy. And this talk will focus on the era of gene therapy. And we're going to be covering some of the US FDA approved genetic modifying therapeutics, as well as some new categories of treatment in this presentation and discussion. Arvind, first of all, I'm really excited to be doing this with you. This will be a fun conversation, I hope. Let's get started by talking about a pretty common scenario. This is a 3-year-old boy who comes in with diarrhea for just a few days, and he's actually eating okay, but parents bring him in to be evaluated for the ongoing diarrhea. His urine is a little dark, and they're worried he might be getting dehydrated. Turns out this boy, in addition to the diarrhea, just has some mild developmental delay. He walked a little late, although now at age 3, he can walk. He has some speech delay. He can talk and he can understand you, but he's just not quite up to his typical peer group. But he's been making improvements over time, and he knows, some single words. And in fact, he can even probably put a few words together, but he's just not middle of the pack, so to speak, in terms of his development, but he's never gone backward with any of that. And in terms of his lab work, just to screen him for his diarrhea and potential for dehydration, it was surprisingly discovered that his liver enzymes were high, even though he doesn't demonstrate any signs of hepatitis. So, Arvind, what do you think the next best step is for this 3-year-old boy with diarrhea?
Thanks, Craig. I'm excited to do this with you as well. Before we get into the answers for the question, let's talk about Duchenne muscular dystrophy. As most of you know, it is an X-linked muscular dystrophy, and it affects mostly males. It affects about 1 in 3,500 live male births, and it is the most severe form of muscular dystrophy. The key thing that we want to look at is how does this Duchenne muscular dystrophy presents, right? Most commonly, these boys present by age 3 to 5 with muscle weakness. However, sometimes these boys can also present with cognitive issues and language issues that the boy that was described in the case. Sometimes these behavioral problems and cognitive problems can also occur even before the muscle weakness gets in. So those could be the initial presenting signs for these boys. So it is always key to watch out for those behavioral issues in these boys with Duchenne. And as we know, it's a progressive disease, right? So most of these boys gets non-ambulatory or use wheelchair by 11 years old. And as time goes on, it's not only a skeletal muscle disease, it can also affect the heart and the lungs. So they can have cardiac issues and respiratory muscle involvement.
When you are, evaluating a boy like this, I mean, I'm assuming you've probably been in this scenario of having been referred a boy who presented with diarrhea and high LFTs.
Yes, Craig. So when we see this high LFTs, right, ASTs and ALTs, and if you see a boy with developmental delay, the one key thing that I always tell my residents, my colleagues, pediatricians, is to check for creatinine kinase, which is a serum creatinine kinase, as you know, that's highly elevated in these boys. I'm talking about, 10,000s, 15,000s in these boys. So nothing else in these kids with developmental delay cause that high CK other than Duchenne muscular dystrophy. So it is always key when you check AST and ALT, and this is slightly high in boys with developmental delay, check CK. And I think that gives you a diagnosis. Or at least if you do that, then the pediatricians can refer them to neurologists before they end up with other specialists. As you know, these boys can end up with GI doctors or hepatologists, and they may end up getting liver biopsies. Even still these days, we see that. So I think, but CK is a simple test. So if you see, or, pediatricians, if you see a kid with developmental delay, with cognitive issues, speech issues, especially a boy, along with your routine workup that you do in clinic, check a CK level, and that will help you a lot, and that'll help with early diagnosis of these boys.
Yeah, Arvind, I couldn't agree more. A lot of the children that I've seen, you're exactly right. They come to me at being referred at around age 3 or 4, but almost always the parents of these boys have noticed problems earlier than that, and they've brought them to be evaluated. Many of them have been in physical therapy for their sort of mild developmental delay. And you get the sense that there's almost a missed opportunity to check a CK, as part of the thought process when you see a boy who isn't walking on time. I think the speech delay, we see that a lot in our boys with muscular dystrophy, with Duchenne muscular dystrophy. And I think that makes it hard for the pediatrician to identify this as a muscle disease. I think it gets lumped into that category of non-specific mild developmental delay. The kids at those young ages, they don't regress. They gain skill at age 2 and 3. And I think most pediatricians are content and comfortable with that. But in these boys, it's a lot more than just run-of-the-mill developmental delay. It's Duchenne muscular dystrophy. And that's why I think it gets missed a lot.
I agree. No, in medical school, right? It's all, when we think about Duchenne, it's a muscle disease, and people don't think about global delays or speech delays. So I think it's all even safer to save anybody that you see with global developmental delay at what point of, doesn't matter, 18 months or 2 years, 3 years, just get a CK because it's cheap and it's easily done.
Arvind,
Awesome.
let me go back to one other point just to emphasize it. The liver function tests and the elevated AST and ALT. My experience has been that it is really easy to forget that AST and ALT, although certainly can come from the hepatocyte, also can come from other tissues. Particularly, it can be intramuscular, and when the muscle's damaged, it leaks out along with the CK. People commonly forget that, in my experience, including sometimes even the GI team doesn't think about that. Have you had that experience too?
I completely agree with you. I just had a patient recently that came for high CK and developmental delay. CK was 25,000. The pediatrician ended up doing, obviously, the liver function test, AST and ALT, and they were telling the family that we have to get a liver ultrasound or a liver biopsy. It literally happened last week. So at least they were reaching out to me, hey, AST, ALT high, so what should I do? And then I had an opportunity to talk to them saying the exact same point. ASTs and ALTs is not coming only from the liver, it can come from the muscle. Maybe they can also check GGT, which I'm sure you do that. If we want to look at specific for liver, GGT might be one that you would want to consider. But AST, ALT, like you said, I agree that it can be high in kids with muscular dystrophies, especially in Duchenne muscular dystrophy also.
We do exactly what you said. We check a GGT, and the GGT is more specific to the liver and does not elevate in our patients with muscular dystrophy, does not result from muscle damage. So the GGT should be normal in a boy with Duchenne muscular dystrophy, but the AST and ALT will be pretty high with the CK at 25,000 for sure.
So we have a 5-year-old boy who presents to my clinic. The family is interested in getting him the gene transfer therapy. So he walks independently. His time to stand, as he's able to stand up from the floor within 7 seconds. And he also has a diagnosis of ADHD. We have some blood work that was done when he came to us. He had mildly elevated AST and ALT. His GGT was normal. And of course, he has high CK and mildly elevated troponin I.
This is a child with, a clinical presentation consistent with Duchenne muscular dystrophy. Most boys get off the floor in less than 2 seconds. So, less than 7 he'll have a Gower maneuver, and it'll be obvious that he can't get off the floor in a normal way. And with that very high CK, most likely has Duchenne muscular dystrophy, and the confirmation is through genetic testing. I'm fine with getting an echo, but it's not the most urgent thing, in my opinion, in this asymptomatic, from a cardiac standpoint, boy with a mild high troponin. and we can get back to the troponin in a bit. The genotyping is not just for the diagnosis, although that is a critical part, but actually now in the era of gene modifying therapy, knowing the specifics of the genetic mutation is really critical to making treatment decisions for the family. The dystrophin gene is the largest gene in the body, 79 exons, and there are a variety of different genetic mutations that cause disease. So it's all in the dystrophin gene, but you can have a problem anywhere along those 79 exons and have Duchenne muscular dystrophy. If you have a mutation in a certain place in the of those 79 exons, if you have a particular type of mutation that disrupts the reading frame, meaning that the protein can't be made from start to finish, some of those mutations are candidates for FDA-approved antisense oligonucleotide therapy. There are 4 FDA-approved therapies, but they are gene specific. So not every boy with Duchenne is a candidate for ASO therapy. You have to have a mutation where these ASOs are targeted, and if they are targeted to that particular mutation, then they can take an out-of-frame mutation and convert it to an in-frame mutation so that the protein can be made from start to finish, even if it is still missing some of that genetic instruction in the middle, let's say, of the protein. So they'll make a smaller and hopefully functional version of dystrophin if they're candidates for this. And we're probably up to, I don't know, probably a third of boys, I would say, are candidates. Would you agree with that?
I do, yeah, 1/3. And I think I also want to point out that someone is, eligible for exon skipping agents, that doesn't automatically exclude them from gene transfer therapy as well.
Yeah, that's right. So we're getting into the nitty-gritty of it because it's such an exciting time to be a neuromuscular doctor because we are getting into the era of gene therapy. And what I like to tell the people I work with is I don't like when people call it gene therapy because that is too broad.
Right.
And that's exactly what you're talking about. Gene therapy doesn't mean just one thing. ASOs are gene skipping therapies, and they're given intravenously, and they're given, every week. Gene transfer therapy is totally different. Gene transfer therapy is a viral vector, an adeno-associated virus vector, although that could change over time, but that's what it is now, that has had its damaging material be removed. So its own RNA has been removed, and it's now functioning like an empty kind of an envelope, so to speak. And you can put in there your own genetic cassette or your genetic payload, and you use this now, quote unquote, harmless viral vector to deliver your created genetic material. And in this case, what is currently being trialed is a very small version of the dystrophin gene. You can't fit the whole dystrophin gene in there because it's way too big. So the current trials are using a mini or micro dystrophin, a very, very shortened genetic code designed to create what we think are the most important parts of the dystrophin protein. And that is a very exciting and new way to approach trying to really change the trajectory of these boys with Duchenne muscular dystrophy. So when I meet a child, the most critical thing for me is what are the genetics? First of all, you need to, as best as possible, confirm the diagnosis of Duchenne muscular dystrophy, which is almost always done this way now. Rarely we have a boy we can't find the genetic mutation. And once you do find the genetic mutation, is that child a candidate for a FDA-approved therapy like an ASO? Depends on their genetics. And are they a candidate for gene transfer therapy, which is less specific for having a specific mutation? So it's not targeted to a specific mutation, but there may be some children whose genetics puts them at an unfavorable risk profile for gene transfer therapy. It's a complicated thing, but remember, we're giving these boys a new protein. This microdystrophin is a protein that their body may have not seen before. And boys that have large deletions or deletions in specific areas of their genetic code, they might not have ever seen this part of the dystrophin protein, and they are at increased risk for having an immune reaction to the gene transfer protein product. So knowing the genetics is really critical for the diagnosis and for determining what the treatment options are.
And also, like you said, to determine if they're increased risk of having this immune-mediated side effect for the specific protein that they're making. So let's look at this video to see how gene transfer therapy works in Duchenne muscular dystrophy.
Gene therapy involves administering foreign DNA, known as a transgene, using a carrier known as a vector. Vectors include modified versions of natural viruses and plasmids that enable the foreign genetic material to enter the target host cell. In Duchenne muscular dystrophy, or DMD, the transgene consists of a shortened dystrophin gene known as mini or microdystrophin. The preferred vectors are DNA viruses, specifically adeno-associated virus, or AAV, which target skeletal and cardiac muscle. Following gene transfer therapy administration, the vector's code, or capsid, binds to the cell membrane of target cells, and the vector is internalized through endocytosis, creating an internal vesicle. The vesicle breaks down, releasing the vector, which transits to the nuclei through a nuclear pore. The capsid is then degraded, exposing vector DNA to the nuclei, where it transforms into episomal DNA. A promoter sequencing next to the transgene initiates the transcription, and the resultant mRNA is translocated to the cytoplasm, where it is translated and protein production begins. Once produced, the mini or microdystrophin is transported to the cell membrane to function.
Craig, I know we nicely talked about the genotype and how the genetic change in a boy is important to consider the gene transfer therapy, right? There are a few other things. Of course, the adeno-associated virus, or AAV titers, that's important, because if you're already exposed to this specific vector, the AAV vector, either through, of course, environmental exposure, or if you had any prior gene transfer, which is unlikely in this point of time or less likely in this point of time, these antibodies can actually neutralize the vector and make the gene transfer therapy ineffective. So it is important to check for those. And the AAV titers on our boy actually came back low. So another thing to look at is a troponin. These boys with Duchenne can have at baseline high troponin levels. The elevation of troponin is important to note. They can have baseline variable levels of troponin that can be mildly elevated. But if they have mildly elevated troponin at baseline, it is important to look at their cardiac function, how good their heart is working. You can do an echocardiogram or cardiac MRI to check at the ejection fraction, and also if they're symptomatic from a cardiac heart perspective, right? If they have chest pain or palpitations. The troponin elevations that we see as an adverse effect in the gene transfer therapies are very high, 10 to 20 folds than the upper limit of the normal. It was significantly higher than what you see in normal Duchenne boy with elevated troponin at baseline.
So we've talked with this family a bit about, the fact that this young man seems to be a candidate for gene transfer therapy. We got the genetics back, we got his baseline labs, we got the low AAV titers, the antibody titers are low, and the family is geared up for wanting to give this a try, and so am I. I'm excited about it. But they want to know, look, there's some risk here. This is the kind of drug where once you give it, you can't stop it and take it back. Once it's in you, it's a done thing. It's a one-time IV infusion. And it involves a big commitment from the family. They want to know, well, what's the benefit? How good is this gene transfer therapy? And to be fair, we're learning about that. What I'd like to show is the evidence behind these gene transfer therapies. And so what Arvind and I are going to do is to go through the trial data for some of the products which are in development. The first that we'll go through is the SRP-9001 gene transfer therapy product. This is through Sarepta Pharmaceuticals, at least here in the US. First study was just in 4 boys who received this. This was pioneered at Nationwide with Dr. Jerry Mendel and his colleagues. And the outcome of interest was the muscle biopsy. So trying to prove that this microdystrophin could be delivered to the muscle and could be expressed in the muscle membrane at the sarcolemma. They also looked at a number of other things, including the functional outcomes of boys with Duchenne muscular dystrophy, and of course, a lot of monitoring of safety. This study included boys 4 to 7 years old, all of whom could walk, and all of whom had a specific type of mutation between exons 18 and 58. That was designed to minimize the likelihood of having an immune response against the protein, which uses exons 1 through 17 and 59 and upward to make the new protein product. So here, the results from this study 101 showed that on average, about 80% of the muscle fibers were positive for this microdystrophin gene product, which is a remarkable amount of transduction. I mean, that's just phenomenal. And they made about 74% of the normal levels of dystrophin. So that's very, very high expression. And this was a very exciting time for us to hear and learn about this. These 4 boys have been followed for 4 years, in fact, now longer. And you can see there in the blue line, they had an improvement in one of their assessments. This is called the North Star Ambulatory Assessment. It has boys walk upstairs, get up off the floor, stand on 1 foot, things like that, jump. So they improved at 1 year, and you can see that their scores have been stable over the next 4 years. So that is not what would be expected in the natural history. And you can see there in the purple, this is an external control group. You can see that they start to decline as they get older. The 101 results and the safety outcomes from 101 led to 102, which again, orchestrated through and run by Nationwide Children's Hospital in Ohio, a larger randomized double-blind study of 41 boys with Duchenne muscular dystrophy, ages 4 to 7, ambulatory. Half were dosed in part 1 and the other half received placebo. And then after 48 weeks, all of those given placebo were treated with the SRP-9001 product. And then they were all followed after 48 weeks from then. They were all followed in an open label version of this study. So basically a randomized double-blind crossover study. Here, what you can see are the outcomes, and these outcomes are stratified by age. The top part shows the 4 and 5-year-olds, and the purple line is the boys that received the therapy, and the yellow line is the boys that got placebo. This is for the first part of the study. And you can see that the 4 to 5-year-olds were well matched between the placebo and the treatment arm, and the treatment arm had an improvement over time compared to the placebo arm, with a higher change in the North Star of about 2 points. In the bottom slide, you can see the 6 and 7-year-olds, and you can see that the 6 and 7-year-old boys were not well matched at baseline. The boys that were randomized to the treatment arm had a much lower baseline ambulatory assessment than boys that were randomized to the placebo arm. And in 6 to 7-year-olds, that's a pretty big difference, because the higher your North Star is, the less likely you are to decline at ages 7 and 8. So what these show is that the untreated boys remained stable and the treated boys remained stable. And the idea here is that those treated boys with starting North Star scores of about 20, they probably would have declined if they had not received medication. But because of this complication with the boys not being well matched at baseline, actually study 102 did not meet its primary outcome, which is a combined analysis of the 4 to 7-year-old change over time in the North Star was actually not significantly different. And we think it was probably because of this imbalance at baseline in the 6 to 7-year-olds. The 4 to 5-year-old outcome was a pre-planned analysis, and that was a part of the study design of 102. Here is the demonstration of the part 2 data. So here from 102 now shown is the crossover group. So those roughly 21 boys that were in the placebo arm then were treated, and here shown in purple, and now they're being compared to an external control cohort. And that external control cohort derived from other studies and other natural history data shows the expected decline in boys of this age and functional status compared to the improvement in boys that were treated. And so that's the favorable outcome from the 102 data. So that leads to the 103 study, Endeavor. Again, the SRP 9001 investigational product. This is a open label study, 4 to 7-year-old ambulatory boys in cohort 1. And actually this study has several other cohorts of different ages and different functional levels, but the largest cohort is this cohort 1. The genetic profile of boys included in 103 is actually slightly larger than boys included in 101 and 102. The main endpoint here is the dystrophin expression, as well as safety and functional changes over time. These boys will be compared to an external control cohort similar to what I just showed you. And so here you can see the outcome of the primary endpoint, which is the change in the muscle biopsy. The vector genome copies are increased per nucleus from none at baseline, of course, to almost 4. The protein expression by Western blot increased 54% on average. Almost 60% of the dystrophin fibers showed positive immunofluorescent staining compared to barely 10% or so at baseline. And you can see also the protein intensity at the sarcolemma. So the microdystrophin protein is localizing correctly to the membrane of the muscle fiber. And these boys improved. Their North Star goes up, and they are faster getting off the floor and faster walking up 4 steps. And you can see there the 52-week outcome.
So there are a few other programs that have dosed boys with Duchenne. So we're going to briefly talk about those other programs, the data that is publicly available. The first one is SGT-001, Ignite DMD by Solid Biosciences. As you could see, the key inclusion-exclusion criteria for these. And this program actually uses AAV9 vectors, and they have dosed 3 low-dose cohort, 6 high-dose, and 3 patients at controls. And the outcomes were microdystrophin expression and safety, and the other outcomes you see here. So if you look at the microdystrophin expression, as you could see, there's robust microdystrophin expression at 3-month time point, and also there's sustained durable protein expression at the last time point, as you could see in these high-dose patients. The last time point would be 12 months, 18 months, and 24 months, and you can look at the % positive fibers and the from the Western blot, the microdystrophin expression. If you look at the interim 2 years functional data on these patients, you're looking at the 6-minute walk test and the North Star ambulatory assessment. The blue line is the treated patients, high dose treated patients, and then the so you have the controls, that is the dark line, and then the dotted lines or the natural history. And as you could see, there's a clear difference in 24-month time mark in both of these functional outcomes between the natural history and the treated patients. The next program is from Pfizer, which is the fordodistrogene movaparvovec. This is a phase 1/2 interventional study that actually had 2 cohorts, both ambulatory and non-ambulatory, and they have high dose and low dose. They had muscle biopsies at 2 months after the infusion, and you could see the primary outcome was safety, and they also looked at some of the other outcomes. And here they also used AAV9 vector. If you look at the microdystrophin expression, again, both normal total dystrophin and also positive dystrophin, positive fibers, there's robust expression of the dystrophin in these boys especially in the ambulatory participants that we are looking at right now. The mean positive fibers at 2 months were 39%, and at 12 months was 62% by immunofluorescence. If you look at the functional outcome, the North Star ambulatory assessment, 1 year follow-up after treatment. In the ambulatory cohort, again, there's the green dots for the high dose and the blue dots for the low dose participants. This is 1 year change in the North Star ambulatory assessments in both of these graphs. And as you could see, these boys actually who treated boys deviate from the natural history with the North Star ambulatory assessment scores.
So Arvind, hearing you present that data just reminded me of how complicated the world of gene transfer therapy is. Here we have 3 different investigational products. They use different viral vectors. The transcripts are slightly different between each one. So, not only are we going to be in a world of, which type of genetic modifying therapy are you a candidate for, but which is, specific for you, or which potentially is better. And this is really just the beginning. There's a lot to come.
I agree. I think not to mention there are a few other programs that are in the pipeline also, not just these 3. So I think it is going to be, it is an exciting time, but it's also going to be more challenging for families and for us.
Yeah, I agree. And that's where, having a detailed conversation with the family and helping them understand what they're signing up for is really critical. Most of the families and that I've spoken with have a very, very basic understanding of what quote unquote gene therapy means. It takes a long time to talk them through it.
So, this boy comes in, has high CK. Obviously the key is the genetic testing to confirm the diagnosis of Duchenne muscular dystrophy, and you do that and you confirm the diagnosis. So can you talk about the multidisciplinary care, how the management of this boy looks like?
Sure. What we're talking about is we're trying to get these children in earlier. That's really the goal of this presentation where you're going to. And you're exactly right. Things have changed so much. We want to see them before they're 5 years old. We want to have that CK checked and have them referred to us. And you're right. We don't do muscle biopsies really anymore, not very often, because we almost always can make a diagnosis now with genetic testing. And that does lead to this whole multidisciplinary care approach to boys with Duchenne muscular dystrophy. Like you mentioned, Duchenne is not just a disease of muscle. It's a disease of other things. It involves the heart. It involves the brain. And so multidisciplinary care team is really integral to the optimal care of boys with Duchenne muscular dystrophy. So it starts with diagnosis. It starts with genetic counseling. This is an X-linked disorder. It presents in boys and it's carried in women, and they may in fact be symptomatic. So there is an element of care for the mother of these children. As you know, a third of the time it's a de novo mutation, so not every mom is a carrier. We manage these boys through a number of different pathways, and it does change with age and need, but they have a rehabilitative care component. Stretching is a real important part of the early care of Duchenne, and mobility adaptation as the boys become weaker so that they can maintain independent functioning is a real critical part of what we do. We need an orthopedist to follow with them to monitor for scoliosis and assist with the contracture management. We do everything we can to sort of avoid surgical intervention as long as or as frequently as we can by being aggressive with splinting and stretching, particularly down at the calves. The families and the boys need counseling. There's a grief process of being diagnosed with this, and the boys also have cognitive issues, so they often need speech and language. They often need extra help in school. ADD is very common, as you know. There's a higher rates of autism in boys with Duchenne muscular dystrophy, so of course you tailor that to the individual. The cardiac management and seeing a cardiologist, that's one of the things we do earliest. We evaluate all of our boys serially with EKGs and echocardiograms. They are at risk for developing cardiomyopathy. Rarely they have difficulties with the conduction in the heart, but they can have PVCs, but rarely arrhythmias. So we monitor for that. Thankfully, those problems don't occur often early in Duchenne, but as the boys get older, those problems become more common, as you know. Same with the pulmonary care. The youngest boys rarely have pulmonary issues, but as they get weaker, the pulmonary management becomes really critical. And we like to have our pulmonologists involved early so that they get to know each family and can be a part of the care plan from an early age. These 5-year-old boys don't need much, but the 10-year-old boys do, and the 20-year-old boys need a lot more. So it's an evolution over time for what they need. Same with the nutrition and GI management. That's rarely needed early, but is needed later. We do try to optimize their nutrition as best we can. And we do start those conversations early, and having a nutritionist involved can be real helpful for some families, especially because we're treating these boys with steroids. That is still the main standard of care, although we're going to get into the conversation about the exons skipping and other gene therapeutics. But standard of care is steroid management, and these boys suffer all the consequences of that, including issues with weight gain, issues with growth impairment. They can have weakening of the bones and even vertebral fractures, and the orthopedist can get involved with that. And the endocrine doctors really help with that as well. So all told, it's quite a lot. And as you know, it's our job to sort of supervise and orchestrate all of this and guide the families through it.
I agree, Greg. I cannot emphasize enough how important this multidisciplinary care is. And it might look too much laboring for the families, but I think it is critical. And we've known that this multidisciplinary care have helped in, slowing down the progression of the disease as well. I always find it interesting when you see these boys, what's our goals of treatment? This is not, it's a heterogeneous population, meaning you're not always seeing the boys at the diagnosis, right? So I'm sure you have boys coming in, followed somewhere else, coming into you, and there are boys who are late ambulatory, who are non-ambulatory. So your thought process of how do you set the treatment goals for these boys now that we have, in addition to steroids, more treatments like you mentioned is on the pipeline?
Yeah, I do like thinking about it the way you're describing in terms of phases, and an easy way to think about it is the early ambulatory phase and the late ambulatory phase. So, we're talking about the 5-year-old boys in the early ambulatory phase and the roughly 10-year-old boys in the late ambulatory phase. And once boys transition to needing a wheelchair, then, which is as best, we're trying to make that into the later teens, but it still is in the earlier teenage years and sometimes earlier than that. But they're still able to sit very easily and raise their arms over their head, and they don't have a lot of scoliosis, and they don't have a lot of breathing difficulties. We call that the early non-ambulatory. And then the later non-ambulatory is when they're having more issues with breathing, scoliosis, and decreased function in the arms, so that their movements are more limited to hand use and more difficulty feeding themselves or performing self-care. And we would call that a late ambulatory phase. And as boys move through these different phases, they need more pulmonary support. They need more nutritional and gastrointestinal support, and they can develop cardiomyopathy, which also can be managed. So our goals of care evolve over time, as you've said. The main goal, overarching goal of care, is to slow the delay. Right now, we can't cure this disease, but if you slow the decline, the boys can reap years of benefit in terms of delaying their loss of ambulation. If you can delay the loss of ambulation, you can offset the scoliosis and reduce the risk that they will need a scoliosis surgery. Just by keeping them walking a few years longer, you can reduce the need for them to have a major intervention in their scoliosis. And by preserving their pulmonary function longer, you can buy them years of not needing non-invasive or invasive ventilation as they get older. So although we can't cure this and we can't really stop it, we do everything we can to try to slow it down, right from the beginning of when we meet them all the way through. And, it's sort of a little bit at the beginning pays dividends at the end is sort of the idea here.
All right, I cannot agree more with you, Greg, in terms of goal setting for these boys. And one important thing is it is a progressive disease. As much as you can preserve or even maintain the disease, it in itself is a realistic goal to have. Where does the PCP, the primary care provider for the patient, comes into play in the multidisciplinary care? How do you involve them in your discussions when you care for these boys?
Yeah, that's a great question. And having an active and engaged primary care provider really is critical for these children and can make their lives so much better. I live in St. Louis. We have people that travel over 3 hours to see me. And I tend to follow boys about once every 6 months. Well, they have a lot going on in between. And these families already spend too much time involved in the medical care, especially with all that multidisciplinary care we just talked about. So having a well-informed primary care provider allows these families to locally be evaluated for when they get their routine illnesses or their coughs and colds. A boy in a wheelchair with weakness who just gets an upper respiratory infection needs to be seen and evaluated because that could potentially be very serious for them. And having a pediatrician or a primary care provider who knows the family, who's familiar with the patient, and who can assess them right there that day locally and triage them, boy, that's worth its weight in gold for these families. So just that right there, I think, really is such a critical part of taking optimal care of these boys. Not to mention, they're on either daily or intermittent steroids, and they may be adrenally suppressed. They may have consequences of chronic steroid use, which can be navigated and managed in concert with the primary care physician. Also, knowing what is and isn't part of Duchenne. That's a common question for families. Is this part of their disease or is this something else? My son's throwing up. Is that part of the disease? No, not really. There's something else there. So all of those sort of routine questions of chronic illness, these children need an engaged primary care provider to help navigate and triage those things.
Yeah, most of the families actually reach out to us first, as you would know, even before they're reaching out to the primary care provider. And I think another piece of the puzzle that is important is our care coordinators that we all have in our clinic. Yes, there are multiple aspects of the care that needs to be taken care of, but you need one coordinator to make sure the boys are getting all of this comprehensive care. And I think that coordinator could be the point of contact to work with the boys' primary care providers.